Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are studying the cover test under the Squint series. So why do we need these cover tests? Now basically sometimes what happens is that your inspection alone will not always be sufficient to determine whether you're looking at a manifest misalignment or manifest squint or not, right? Sometimes an epicanthus, a facial asymmetry or a wide angle kappa can also simulate a deviation, right? So basically what I'm trying to tell you is that sometimes in examination it becomes difficult just by inspection to differentiate whether we are dealing with a pseudo strabismus or a true strabismus. So in that case your cover tests become very handy. But what is the idea behind these cover tests? So covering one eye of a patient with a cover basically disrupts or interrupts the normal binocular fusion, right? So that's the idea of doing a cover test. So as we are doing a cover test, what we are doing is we are basically disrupting this fusion. So what do we basically need to carry out these cover tests? So we need basically some fixation targets, right? Because the cover test should be done at near and distance. Okay. Now for near, the distance is usually about 33 centimeters, and we need to have these correct fixation targets for use. Example, shown in this picture. So your fixation targets can also have these numbers, and they can also serve very well as accommodative targets. Now for distance, however, how much distance you choose, usually it's about 6 meters, and the smallest letters, however, that can be seen clearly with the eye with the poorest vision is chosen as your fixation point. For example, if there's a patient in whom you want to carry out the cover test, say the right eye has a vision of 612 and the left eye has a vision of 618. So which eye is now the eye with poor vision? It is the eye with 618 vision, right? So in such a patient, you're going to choose a target of 618 for distance fixation and to carry out the cover test at distance, right? Now, what about kids? We know that kids do not have a very good attention span, so they do not usually, fixate very easily. So for them, you can use a fixed toy, which is also having some sort of added auditory stimulus, or sometimes you can use some remote control mobile toys or videos, to achieve fixation in case of pediatric population. Apart from that, what do you need? You need basically needs covers to carry out the cover test. So the most common one that is used is a black paddle occluder as shown over here. However, you also have some sort of occluder which is translucent, made up of a rigid non-reflective plastic, which actually allows you to assess the eye position behind the occluder as shown here in this picture, right? So this is called a Spielman's occluder. Now the patient's view is definitely reduced to some sort of indistinct blur. Okay, so definitely using a translucent occluder also, you are breaking down the fusion and you also minimize the accommodation. However, when you talk about the efficacy of a translucent occluder or a total black occluder, definitely your paddle occluder, that is a black occluder, will be more dissociating compared to your translucent Spielman's occluder. Now, there's an important clinical point here, that Spielman's occluder is actually used to diagnose your dissociated vertical deviation. Now, in dissociated vertical deviation, what happens is as you put the eye under cover, the eye basically behind the cover will very slowly drift in an upward and outwards direction, right? And that is called dissociated vertical deviation. And the phenomena is called the Belchowski phenomena. And here the occluder that we use is the same Spielman's occluder, right? Because you can very easily, observe the movement of the eye behind this translucent occluder. Now, what are the types of cover tests? So basically, we'll be discussing cover tests under three headings, and there are three types of cover tests. So these are the normal direct cover test or the cover test. Then we have an uncover test, also called cover uncover test. Then we have an alternate cover test. First, let us talk about the cover test or the direct cover test. So how do we do cover test? Now basically cover test is done usually in cases where we have an already apparent squint or a manifest squint. For example, this patient has a right eye exotropia. right? Now here the normal eye or the fixating eye is a left eye. So what are we going to do? We are going to place cover in front of the left eye, and now we are going to observe the right eye for its corrective movement. Now as you cover the fixating eye, which is the left eye, the right eye is now going to take fixation, right? So if the right eye is going to take fixation, it has to basically come from the strabismic position towards the center. Now here the right eye was actually present outwardly deviated, and therefore in order to take fixation it is supposed to move towards the left side, that means inside, right? Now as we know, the Hering's law of equal innervation says that there will be a corresponding movement in the left eye as well, and therefore the left eye is also going to move towards the left side. Example, you can see there is actually a translucent occluder here, and as you can see, as you have put a translucent occluder in front of the left eye has also moved towards the left side. Although what I want you to remember here is that in cover test you are going to observe the movement of the eye which is not under the cover. Okay, you're going to observe the movement of the eye which was initially strabismic. So here the movement of the right eye, which was strabismic before, which was having exotropia, is inwards, right? So here what happens is basically, for example, if a patient has esotropia, when you put cover in front of the other normal eye, this eye will actually move outside or temporally in order to take fixation, right? So that actually confirms that what you're looking at is esotropia. Similarly, if the eye was originally present outwards, that means if originally there was exotropia, the eye is going to move inwards in order to take fixation. Similarly, if the eye was deviated upwards, that is hypertropia, when you place cover in front of the fixing eye, the normal eye, the eye has to move downwards, and this indicates that the patient had hypertropia to start with. Similarly, if the eye is moving upwards on placing the cover in front of fixating eye, it means that the patient originally had hypotropia, right? So basically you place cover in front of the normal eye or the straight eye or the fixing eye, and you look for the movement in the squinting eye, and based on the movement you will tell whether it was esotropia, exotropia, hypertropia or hypotropia. So I hope that is clear to you now. Now, sometimes it's not really important that you carry out cover test only if you have very large squint present. Now, sometimes you might be confused whether you are dealing with a proper squint or is it a pseudo squint. Now, in those conditions also, your cover test can become very handy. Now, suppose you do carry out a cover test basically in both the eyes. So first you cover one eye and look at the movement of the other eye. Suppose there is no movement in the fellow eye, you cover the other eye and then look for the movement, right? So when there is no movement of the fellow eye, when either of the eye is covered, then you can, with confidence you can say that there is no manifest strabismus at least present in this patient, right? So when there is no movement in either of the eye, on covering either of the eye, that means if you cover the right eye, there's no movement in the left eye. If you cover the left eye, there's no movement in the right eye. It means that there is no manifest strabismus present in this patient. Okay, so I hope that is clear. So for example, here you can see that the patient looking straight ahead in the first picture. The second picture, we have placed a cover in front of the left eye, and what is happening to the right eye? The right eye is the same. There is no movement in the right eye. Now let us check for the left eye. In the left eye, for checking the left eye, we are putting a cover in front of the right eye, and is there any movement in the left eye? No, there's no movement in the left eye. So what does it indicate? It indicates that this patient is orthophoric. Okay, that means there is no manifest strabismus present in this patient. So how do you interpret these results? Basically, on covering the seemingly fixating eye, the normal eye, if there is no movement of the other eye, it means that there is normal binocular fixation present. That means there is no manifest strabismus. If there is a movement of redressal, okay, so that squint eye will come back to the center to take a fixation, that is called a redressal movement. So if there is a movement of redressal in the other eye, it means that a manifest deviation was present before you have applied the cover. So I hope that is very clear to you. Okay, next we go to what is meant by indirect cover test. Now till now what we were talking about was a direct cover test. Now we go on to indirect cover test. Obviously, a child when it comes to your clinic will not let you apply the cover so easily as an adult. So in such a case, you will actually apply your cover or occluder from a distance, right? So this test, which is termed as indirect cover test, it does not permit a full interruption of fusion as in case of the direct cover test. However, it can be useful in case of infants and small children who have heterotropia, and will allow you to assess such kids. So this is called indirect cover test. So, a very important clinical nugget in the same context is that of an infant who starts crying when you put cover on one of his fixating eye. So, what does it mean? It means that the eye which has squint actually has very poor vision. Okay. Similarly, sometimes when you put a patch, what happens is the other eye will start developing some sort of searching or nystagmoid movements. So such nystagmoid movements are indicative of the fact that the child actually has amblyopia. So do you see that the cover test is so important? It can actually estimate your and sometimes give you a diagnosis of amblyopia in case of infants. Now coming to the cover uncover test. Okay, so what happens in case of phoria or latent strabismus is that when you cover the fixating eye, okay, the eye which is not covered will not show any movement. So in case of phorias, you are not going to see any movements, right? And the eye which is behind the cover, however, if it has any sort of phoria, it will show some sort of movement. So here is a very important point that with cover test, you can definitely eliminate a component of tropia. But can you eliminate phorias? No. You cannot eliminate phoria or latent strabismus by simply doing a cover test and observing the other eye. You need to observe the eye under the cover to determine the presence of phoria or latent strabismus. And that is the principle behind doing a uncover test. Okay. So let us see how do you do a cover uncover test. Basically, one and then the other eye is covered while the patient is maintaining a fixation. So you give patient a fixating target and now you start covering one eye and then the other eye. But here the attention of the examiner is towards the eye which is covered. Okay. In the cover test, we were looking at the other eye and not at the eye which was covered. Here we are looking at the same eye that we are covering with our cover. Okay, so that is your cover uncover test. If the patient has some sort of heterophoria, the eye is going to deviate behind the cover, okay, in the direction of the heterophoric position. So for example, if a patient is there and he has a exophoria in right eye, as you place cover in front of the right eye is going to deviate outward, or that means towards the right side, okay, behind your cover. So that indicates that the patient has a phoria. And as soon as you're going to remove the cover, the eye is again going to become center under the influence of fusion, and therefore the eye is going to move inwards from its outward position, right? So that is very important point for you to remember. For example, let us see this patient. Now this patient seems to be actually orthophoric. Both the eyes seems to be looking straight ahead. Now can this patient have a component of phoria in him? Yes, definitely. So what do? We carry out a cover uncover test. So in cover uncover test, you can either use your black occluder, or if you want to simplify the process, you can actually use a translucent Spearman's occluder as shown here in this picture, right? So here you can see that as you have put the occluder in front of the right eye, the eye under the cover has moved out. So what does it indicate? What did I tell you? That whenever the patient has heterophoria, the eye will tend to move towards the heterophoric position behind the cover. So here the eye is moving towards the outside, that means behind the cover, that means the patient has exophoria. And as soon as you do the uncover test, that means as soon as you remove the cover, what do you see? The right eye is moving back towards the center, and in order to move to back toward the center, it has to actually move from outwards to inwards in this direction, right? So if you have a translucent occluder like this, you can actually observe the eye behind the cover, and then you can remove it and observe it, observe the movement of the eye on uncovering as well. However, if you have just a paddle black color occluder, you're going to basically look for the movement in the third picture, right? That is the redressal movement. Okay. So basically your cover uncover test is giving you a clue regarding the presence or absence of phorias. So that is very, very important. Now let us see this. Now in the first picture you can see that when you cover the right eye and when you uncover the right eye, because we're talking about the uncover test, you see that there is no movement in the right eye, right? That means there is no phoria in the right eye. Now let us test the left eye in the picture B. Okay. Again, you do remove the cover. That means you have uncovered the left eye and you see that there is no movement in the left eye. That means on uncovered test in the left eye, there is no movement. That means there is no phoria present in the left eye as well. Now what about this picture C? In picture C, as you uncover the left eye, the eye seems to be moving outwards. Okay, so what information does it give it to us? It tells us that maybe the eye was inward behind the cover. So here the eye is moving outwards. That means the patient has esophoria. In the D picture, you can see that the eye, when it is uncovered, now it is moving inwards. That means the patient had exophoria. In the image E, labeled as E, you can see the eye is actually moving downwards. That means it was originally upward behind your cover, right? So on uncovered test, the eye is moving downward. It means that the patient has hyperphoria. Now on uncover, as seen in this F labeled image, the eye is moving upwards. It means that the patient has hypophoria. So I hope that is clear to you. Now, so digest that information, and next we go to the importance of the speed of recovery. Okay, so all that eyes, moving up, down, inwards, outwards, I told you that it's called redressal movements, right? So you also observe on cover test with what speed the eye is actually redressing backwards. And why are these eyes moving backwards toward the center? They're coming back toward the center to take fixation, right? So it gives you a clue regarding the fixation as well, right? So you basically observe the speed of recovery in case of these deviations, especially in case of phorias. You check how rapidly the eye is moving toward the center. Is it a rapid redressal, a moderate redressal, a delayed redressal? And sometimes the patient has to actually blink the eye, to bring the eye back toward the center, right? So as you place the cover, the eye is going to move towards the heterophoric position, and if you remove the cover, you're not going to see any redressal movement. That means the eye is almost fixed there. It is only a matter of fact that the patient will blink and then the eye is going to come toward the center, right? That actually tells you that the patient is having a very poor control of his phoria, and his phoria is going to soon decompensate, and the patient is now going to have atropia or a manifest strabismus. Similarly, sometimes these patients will also complain of diplopia before the redressal movement, and this happens in delayed redressals or redressals which actually need a blink, for it to recover. Now, sometimes there will be no recovery at all or a very poor control heterophoria. So, as you can understand, this is actually a spectrum. So, first of all, you will have a phoria. That phoria is going to decompensate, and now the squint will become, more often. It'll appear more commonly now, but still it is intermittent. It is not present all the time, and gradually it will become a total manifest squint or a constantly present squint, and that is called atropia, right? So aphoria leading to intermittent deviation, leading to a manifest or constant tropia or squint. Now the third type of test is the alternate cover test. So what is this alternate cover test? So as the name suggests, alternate cover test means you're going to alternatively cover one eye and the other, and then look for the movement in the other eye. For example, here the patient seems to have exotropia in the left eye. Okay, now you place the cover in front of right eye. What is happening to the left eye is that the left eye is moving inwards, right? That means there was exodeviation in the left eye. Now, if you cover this left eye, what is happening? There's a redressal movement seen in the right eye. The right eye is moving inwards now. That means there's exotropia present in the right eye as well, right? So what you're dealing here is, we are dealing here with is the alternating exotropia. right? So this is your alternate cover test. So basically you have these cover uncover test and the alternate cover test. One point that you should remember is that the alternate cover test will fully dissociate your eyes compared to your cover uncover test. Okay, so you can break the fusion much in a much better way with an alternate cover test compared to your cover uncover test, and therefore an alternate cover test is of great value in phorias and in tropias regardless, right? So your entire deviation can be brought about. You can get an exact estimation of the maximum deviation only by doing an alternate cover test. So as we go ahead and discuss the prism bar cover test also, you will realize that these tests are also done with an alternating cover test. Okay, so whenever you try to measure the deviations, you have to do it with an alternating cover test, because alternating cover test will fully dissociate your eyes and bring out the maximum deviation or the true deviation. However, another important point is, if you would have observed, this alternating cover test is actually seems to be a mixture of your cover and uncover test. So as you're alternatively covering one eye and looking at the other eye, you really do not get the exact information whether you're dealing with a latent or manifest deviation. It could actually be a mixture of both, right? So it's useful for measuring. However, you can't put a label on it whether it is just a latent or a manifest deviation just by doing an alternate cover test, right? And this is why it's very important to do all the three cover tests systematically. So I hope you got it by now. So now let us summarize and see if we can jot down all the important aspects of the cover test. So the cover test is a very important method by which you can differentiate manifest strabismus, latent strabismus. You can know about the direction of deviation, whether it is a horizontal squint or it's a vertical squint, right? So horizontal are your exo and esos, and vertical is your uh, hyper and hypo deviation. Then you can also differentiate the different angles by doing cover test at near distance and cover test at distance fixation. You can also study about the effect of accommodation and the patient refractive error by doing cover test. This you will understand when you study esotropia, in which we have accommodative esotropia, okay, where we actually give the patient refractive correction, okay, your convex glasses, and then do the cover test and look at the deviation angles. Obviously, by doing cover tests, you get to know whether you're dealing with a phoria or a tropia. Sometimes it gives you information regarding whether it's a constant squint, whether it is coming and going off, whether it is unilateral or it is alternating kind of squint. Of course, you get an estimation of visual acuity also. As I told you, in case of infants, if there is nystagmoid movements, you get an idea whether the patient has amblyopia also. The speed of recovery in latent strabismus can tell you how good is the control, how good is the fusion, is the patient going to decompensate very soon from phoria to tropia. So therefore, your speed of recovery is important. Again, sometimes you can also judge the presence of latent or manifest latent nystagmus. So latent nystagmus is a nystagmus which is usually absent, but when you put a cover, the eye starts showing oscillating, right? Oscillations. So that is called a latent nystagmus, which appears only if you cover one eye. Manifest latent nystagmus is a nystagmus which is present, but once you cover one eye, the nystagmus is going to increase in its intensity or amplitude, right? So that is called a manifest latent nystagmus. So here also your cover test comes very handy. Similarly, you can find a latent component in case of infantile nystagmus, and also as you go ahead in your squint examination, you will find out that all these tests, especially the alternating cover test, we actually do it in all the directions of the gaze. You measure your deviation in all direction of the gaze by asking the patient to look towards the right, left, up, down, dextro elevation, levo elevation, depression, okay, simultaneously. So if your angle of deviation is equal in all the direction of gazes, it is called a comitant squint. Whereas if the deviation angle actually, or if your exotropias or esotropia, or in simple terms, if the squint is variable in different direction of the gaze, it's called an incomitant squint, right? So your comitance and incomitance can also be found out by doing an alternate cover test. Okay, so that's all for today. I hope it was useful. Thank you and have a nice day.